I'm very pleased to be with you today, unfortunately still virtually, but I'm very much enjoying the meeting. Paulus has asked me to talk about early rhythm control therapy to improve outcomes in patients with AF, and specifically to describe the East AFNET study and its implications, which are on the left of the slide. Let me start by reminding you, of course, that we have had 7 so-called rate versus rhythm control trials, most of them conducted over a decade ago. They show little or no difference, certainly no advantage to rhythm control for the most part, and trends towards advantage for rate control. But this did not sit well with most cardiologists, and especially rhythm doctors, who could not believe that it was not better to be in sinus rhythm than in atrial fibrillation with rate control. Many potential explanations have been put forward. Some of these seem to have some partial explanation for the results, but many of these remain entirely speculative. The design of the East AFNET 4 trial is as follows. Patients at relatively high risk of outcome events were enrolled, particularly if they had recent onset atrial fibrillation, meaning less than 1 year from the original diagnosis. However, patients without a known AF diagnosis, the time of the diagnosis was unknown, could also be enrolled. And this is one point which has been criticized about the design. The patients were then randomized into one of 2 strategies, either early rhythm control or usual care. Usual care implied following the guidelines, in other words, rate control, unless rate control was insufficient to reduce symptoms sufficiently, in which case rhythm control could be instituted. It's important to point out that this was not a trial comparing early rhythm control with late rhythm control, nor was it a trial comparing rhythm control with rate control. It compared 2 strategies with elements of both of the above comparisons. There was a composite endpoint, CV death, stroke or TIA, heart failure or acute coronary syndrome, hospitalization. Another criticism was that CV death was in this composite rather than all-cause mortality. The patients were followed on optimal medical therapy plus their assigned treatment from the randomization. About 1,400 patients were randomized to each of the 2 strategic arms of the trial. Importantly, about 30% had some extent of heart failure. About 40% were enrolled after their first episode of atrial fibrillation. The median time from diagnosis, when the time was known, to enrollment was just 36 days, and about 1/3 of patients were asymptomatic with an EHRA score of 1. There was not much difference between the underlying treatment, and we can see that it was pretty well established in both groups. There was a small difference with regard to rate control being greater in the group that was eventually assigned to usual care. If we look at rhythm control in the 2 limbs of the study, we can see that it started out at about 95% with active rhythm control in the early rhythm control group, and by 2 years, this had dropped to about 65%. If we look at the usual care group, we can see that about 5% had rhythm control at the start of the trial, and it rose to about 15% by the 2-year time point. If we look at ablation, we can see that that occurred in both groups, but it was earlier and more in the rhythm control group than in the rate control. Now we see the main outcomes of the trial here. The composite outcome was reduced by some 21%, and it was statistically significant. The trial was stopped early because of this finding. If we look at the components of the composite outcome, we can see that CV death and stroke were both significantly reduced in their own right, and hospitalization for worsening heart failure or acute coronary syndrome were numerically less with early rhythm control, but not in themselves statistically significant. The second primary outcome was not different between the groups, and that was the nights spent in hospital per annum. And the reason that this was a second primary outcome is that this was a finding in the rate versus rhythm control trials that more hospitalization was required for those with rhythm control. Now, in order to assure the activity of rhythm control in the trial, it was decided to have some extra monitoring in patients in the early rhythm control group. And there has been a concern that there may have been more interaction with physicians with the early rhythm control group than the usual care group. And we see that this is in fact so. There are about 2.13 visits per patient in the early rhythm control group and 1.94 visits per patient in the usual care group. We can see that this is not related to the scheduled visits, of course, but to visits which were triggered or for other unscheduled reasons. Most of these took place relatively early during the trial. What we cannot calculate, of course, is how much further interaction and improved medical care was offered to those in the early rhythm control group compared with the usual care group. But the assumption is that it was not much different. Looking at now the asymptomatic patients in the trial, about a third, you'll remember, were asymptomatic, and we can see that there was a numerical reduction within the asymptomatic patients with the composite endpoint, and we see that the hazard ratio was about 0.76. It was a little higher in symptomatic patients, but you can see that this was statistically significant. 2/3 of the group versus 1/3 of the group, of course. Looking now at patients with heart failure, and you remember about a third of the patients also had heart failure, we can see that looking at all the heart failure patients together, that the outcome here is very similar to the outcome of the trial in general, and the result was statistically significant. Dividing heart failure into patients with a reduced ejection fraction, a mid-range ejection fraction, or a preserved ejection fraction, we see that in all instances, there are numerical reductions in those who had early rhythm control compared with those who had the usual care. But of course, it was not statistically significant in any of these smaller groups. But on the other hand, we can see that most of the difference seems to have been, at least in the early part of the trial, in those with the reduced ejection fraction. Interestingly, using the CASTLE-AF endpoints, there was also a statistically significant reduction associated with early rhythm control, although this was not so with the Cabana endpoints applied to this trial. Now, there have been several follow-up studies once East AFNET 4 was published, and one came very quickly from an analysis of the AFFIRM data. They divided their patients into those who had new AF, meaning within 6 months of the study enrollment, and those who had atrial fibrillation, which occurred well before the 6 months prior to enrollment. You can see that with regard to these endpoints, mortality and ischemic stroke, there is no difference between those who had relatively early onset AF when randomized and those who had later AF. There was also an analysis of the EHRA long-term general registry for atrial fibrillation. And this had recruited at that stage 10,000, nearly 11,000 patients, and 34% of those were suitable for inclusion in the study. Early rhythm control was associated with a better quality of life, but with greater use of healthcare resources. The primary outcome was in favor of early rhythm control, but when models of adjustment were applied, the significant differences evaporated. Another study reported from the Korean National Health Insurance Service demonstrated that patients who had early rhythm control, meaning less than 1 year since diagnosis, and looking at the same composite endpoint, we can see that that was very much in support of the results of EAST AFNET 4. And with late rhythm control, there was no difference between that form of rhythm control and rate control. So finally, if we assume that early rhythm control does in fact have advantages, and I believe there is more to establish yet before we can be sure of that, then it would have major implications for our approach to atrial fibrillation. We certainly should not be waiting for symptomatic failure in terms of rate control before moving to rhythm control, which should probably be offered at a time when the substrate is largely trigger dependent and the arrhythmia is very early in its development. So with that, thank you very much for your attention.